Hello, everyone. Welcome to the Healthy Joints, Healthy Lifestyle Show. And I have a superstar here with me today, Dr. Lilanjana Bose. But for those who don't know me, my name is Dr. Aminola Dada. I'm a rheumatologist in the greater Seattle area. And today I'm your host, and I am welcoming my dear friend, brilliant, accomplished, amazing rheumatologist, Dr. Lilanjana Bose, who has a private practice called the Lonestar Rheumatology LLC that she founded just in 2022, and it's already grown. I mean, she is just a monster in a good way, in a good way, in a good way. So, Dr. Bose, I'm going to let you kind of introduce yourself. I mean, you and I know you went to Cleveland Clinic for fellowship. You are well authored. You are every time I go to any conference, actually arthritis, didn't you stand up on the stage at RPPA? Went you on the stage a couple of times doing some of our national conferences? Yes, you were. I don't worry, I'll answer for you. Yes, you were. But I'm gonna let Dr. Bose introduce herself and just say a few words about her practice, just so that you get a feel for who she is and the megastar that we have on the show today. Welcome.
Thank you, Dr. Dada. Great inspiration. And hello, everyone. My name is Nilanjana Bose. I'm a board certified rheumatologist. I'm based in Houston, Texas. I have been in the rheumatology sphere for over, I don't know, 14, 15 years now. And yes, I did launch my own clinic in 2022, and we've been very blessed with the growth. It's a solo private practice, and we love what we do in helping our patients every day there.
And I can tell that every time I talk to you. So we are going to get right to it. So tell our audience a little bit about, why you do what you do.
Great question, Dr. Dada. I think we all have to, if you don't enjoy what you do on a daily basis, your work becomes a chore. If you enjoy what you do on a daily basis, your work becomes a calling, right? So I do, and I'm sure you do, what we do is because fundamentally we are physicians, we're healers, we want to help people, we want to ease their suffering. And as a rheumatologist, I think we're uniquely positioned to help a lot of patients understand their disease, treat their disease, prevent complications, and lead a
Yeah.
good, healthy life.
I couldn't have answered it better.
Thank you.
So, what inspired you? Although there's a little bit of that in that question, tell me what inspired you for rheumatology, because I think all doctors, some doctors, maybe not all, because we're special as rheumatologists. What inspired you to become a rheumatologist, though?
So I've always loved internal medicine. So I am an internist, and while doing my residency in internal medicine, I really liked rheumatology. I didn't know much about the field. I did a rotation in rheumatology. Really liked the cases we saw, the complicated cases, but yet the very um, you know uh, unique way in which we follow our patients lifelong. And I really liked the cerebral approach to medicine. So that's how I became a rheumatologist.
Okay, perfect. So today we are going to talk about rheumatoid arthritis. And for people who may not be familiar, what exactly is rheumatoid arthritis? As different from rheumatism, what exactly is rheumatoid arthritis and how does it differ from all the other kinds of arthritis out there?
So rheumatoid arthritis is not a very common kind of arthritis, right? It is a disease that affects the joints, and it is an inflammatory disease where your immune system gets hyperactive and starts attacking the body. In rheumatoid arthritis, it's not only your joints, we also worry about your other organs getting involved due to systemic inflammation. We compare this with osteoarthritis or degeneration, where there's wear and tear and a degeneration in the joints, but there is no systemic inflammation.
Yeah. Yeah. So exactly what I tell my patients often is osteoarthritis. That if we live long enough, we'll all get a little bit of osteoarthritis. Right. But rheumatoid arthritis can affect anybody, even
Right,
kids.
right.
Okay. So what are the first signs? I think that's what a lot of people, I think once everything is swollen and inflamed, they know something bad is happening. But I think people really want to know what those first signs that they can kind of watch for that may make them think of rheumatoid arthritis versus something else.
Right. And I'm sure, Dr. Dada, you have your own perspective. A lot of times we are now getting patients being referred to rheumatology earlier because our primary care colleagues, our orthopedic colleagues are more aware. I think for patients, if you are noticing joint pain, joint swelling, fatigue, prolonged morning stiffness, maybe low grade fevers, abnormal blood work that is not being explained, talk to your primary care doctor or your physician and see if you can see a rheumatologist. The sooner you can see us, the better it is, and we can try to find out what exactly is going on. It may not be rheumatoid arthritis, or it may be something very early on that we could intervene.
Okay, that makes sense. Do you, the fatigue is so interesting though, right? It's such a common symptom, but I agree with you that that morning stiffness plus the fatigue probably should be investigated.
Yeah. In someone who's otherwise been pretty healthy, right?
Yes,
Suddenly.
exactly. Yeah. Okay. So, many people wonder how RA or rheumatoid arthritis is diagnosed. Can you kind of walk us through the process?
So again, rheumatoid arthritis, it's a pretty intense, complicated process. Not for us as rheumatologists, but maybe it seems complicated. To us as rheumatologists, we follow a very scientific approach. So first, we will evaluate the patient with a great, very detailed history, physical examination. We review available labs and imaging. Then, based on our diagnosis, if we are suspicious of rheumatoid arthritis, we order our own labs, imaging, hopefully some more detailed imaging, and then we can start you on some medicines that can help give you some immediate relief. And then, based on the findings of all your test results and the response to therapy, we can come up with a detailed treatment plan.
Yeah. So when you say imaging, what do you refer to?
So imaging can, involve X-rays, ultrasound, MRI, some of which are more sensitive than others.
Yeah, yeah. And I love the fact that you're saying, hey, if the patient comes to you, you're going to order this blood test, you're going to order these x-rays and stuff, but you're also going to try to get the patient comfortable.
Yeah.
Because a lot of times people have waited a long time to see the rheumatologist. And I think it's reassuring to know that, hey, your pain is going to be acknowledged while we try to figure out what the exact diagnosis is. We can try to moderate your pain depending on how uncomfortable you are, so that you don't have to continue to suffer while we try to figure out the puzzle.
Right. Exactly. Yeah.
So we've ordered blood tests, we've ordered x-rays, and then we've started on, and then what next though? What next? So you've started the patient on, we've started, on something to kind of help our symptoms. What are kind of the lab tests that would be positive, for instance? What would the x-rays show? Can you walk us through that process? Second part B, visit two.
Sure. So it all depends on your the kind of rheumatoid arthritis you have. You could have seronegative rheumatoid arthritis, which is you don't have the conventional markers, the rheumatoid factor CCP, or you could have the more common seropositive rheumatoid arthritis with both rheumatoid factor CCP or either or being positive. Lab wise, I also look for unexplained anemia, high platelet count, elevated inflammation markers like a CRP and ESR. Um, these are some of the clues that can key us in on early unexplained inflammation. Imaging, of course, we can see evidence of erosions. That is usually a sign of progressive or long-standing disease. Early rheumatoid arthritis is not very well defined on X-rays, but if we have access to ultrasound or MRIs, we are able to see early inflammatory changes, synovitis, bone marrow edema, and that can help us understand your disease better and come to the diagnosis better.
Okay. Well, let me help our audience break that down a little bit, because from one rheumatologist to the other, we are just having a good old time talking about our serologies and everything. But if we want to break that down a little bit for our audience, let me start off with the word that kind of first of all stood out, erosions. What are erosions?
So erosions are really tiny pieces of bone that get eaten away by these
Mm,
inflammatory cells, the cells that are all over your body because of the systemic inflammation.
yeah. Yeah, okay. And so those are the erosions, that Dr. Nilanjana is saying that you can see that damage on x-rays and it's pattern recognition, right? Rheumatoid arthritis looks a certain pattern on x-rays, osteoarthritis has a different pattern. So when we have seen so many X-rays, we can point out, oh, that's a rheumatoid arthritis X-ray, and that's a psoriatic arthritis, that's osteoarthritis. So different kinds of arthritis may have different presentations on X-rays. And then the other thing you did, Dr. Nilanjana, which I just enjoyed the way you just spat out all those serologies. Can we kind of just go one by one through that? Because I think a lot of times people these days, they get their labs before their doctors even see their labs. And that's a blessing and a curse because people are now spending sleepless nights waiting for the opportunity to have this conversation with their doctor because they got it even before the doctor. While the doctor was sleeping, they've already gotten their labs. And so maybe if we could just run through those serologies that we mentioned, just so that people can, I'm sure people are probably taking notes. So just so that they can like really understand and digest each one of those. I think you mentioned like five at least different things.
Yes, so some of the markers specific for rheumatoid arthritis is the rheumatoid factor, very, very commonly ordered tests. Please keep in mind that there can be false. I don't know if you should call them false positives, but you can have a rheumatoid factor and not have rheumatoid arthritis.
Yeah, yeah.
But since we're talking about rheumatoid arthritis, we're going to presume that the patient coming to us has evidence of rheumatoid arthritis. So the rheumatoid factor being elevated, usually the rheumatoid factor when high is usually in the hundreds or even thousands. So, highly elevated rheumatoid factor is definitely points us in the direction of rheumatoid arthritis.
Yeah.
The second marker we talked about, Dr. Dada, is an anti-CCP antibody. Again, a very specific marker for rheumatoid arthritis. When you have these markers, there is a higher risk of what we call extra-articular disease. That means disease which goes beyond your joints to affect your organs. So, your lungs, your heart, your eyes. This is where we as rheumatologists take extra care to make sure we are treating your disease aggressively. The other markers, Dr. Dada, we talked about were the indirect markers, right?
Yeah, we mentioned the indirect markers too.
Yes. So for example, if you're having evidence of anemia without evidence of any bleeding, then the anemia may be caused by the chronic inflammation in the body. That is a clue for diseases like rheumatoid arthritis. I also look for unexplained high platelet counts. It's called thrombocytosis. That can explain ongoing inflammation. The other ones very commonly used are markers of inflammation, ESR and CRP. Please keep in mind these are non-specific and can go up even if you're having a flu or sinus infection.
Yeah, yeah. Well, thank you for that explanation. I think that really helps people kind of take a little bit of that in. But you mentioned something else. You can have rheumatoid arthritis outside your joints. Please explain.
So this is called extra-articular manifestations. That it basically means that rheumatoid arthritis is a disease that can affect your whole body. It is not just restricted to your joints, which is why we as rheumatologists take such an interest and care to make sure all our RA patients get the correct care. Because without aggressive treatment at the right stage of their disease, this disease can continue to progress. You may be able to tolerate pain. You may be a great, your pain tolerance may
Yeah.
be great, but if you don't treat the inflammation, you might incur damage to your joint, to your organs, right? So lungs,
Yes.
heart, eyes. So this is why we have to be very, very careful.
Yeah, yeah. So you're so right because people think, hey, it's just my joint, it doesn't matter. I can bear the pain. I don't really care about the pain. And you talk to them about joint damage and it doesn't really make an impact. But think understanding that it's not just your joint, it's a whole systemic inflammatory process. Your whole body is waging this war against your joints. And it can also have like collateral damage. So it can cause like eye involvement, lung involvement, heart involvement. So yeah, I just wanted to kind of let our audience know that rheumatoid arthritis is not just a joint issue. And I totally agree with Dr. Nilanjana that it's very much a systemic condition. Okay. So there's a lot of information online about the different treatment options. So, what are the most effective, kind of up-to-date ways to kind of manage people who have kind of, moderate to severe disease? Let's start with that. Or who have kind of really, really, difficult RA. What would you? I guess I should not limit you. Let me just let the whole spectrum walk you through kind of low, moderate, and severe.
So I think it really depends on how the patient presents to us, right? So if it's a patient with a lot of swollen and tender joints, I think the treatment paradigm that we use in the United States is very similar. Most rheumatologists will start off at the initial visit with some sort of steroids. And while steroids carry a very negative connotation, I explain to my patients that steroids are great options when used correctly and effectively, right?
Yeah,
So steroids are actually my number one method of treatment for rheumatoid arthritis, both in the short term and long term for only for flares.
yeah,
We use DMARDs, disease modifying anti-rheumatic drugs. These are older drugs, they are oral drugs, they're usually safe. We have to tailor the treatment based on the patient, the gender, the
yeah.
age, potential for childbearing.
Yes, yes,
So DMARDs are usually your first line of therapy. There are medicines like hydroxychloroquine, which is safe for women. It's a big added plus, and of course methotrexate,
yeah,
sulfasalazine.
yeah,
Once we've tried these medicines, maybe for a couple of months, 2 to 4 months, depending on the disease status, we can consider either adding on a second DMARD and or adding on a biologic. So again, biologics are the next step. These are our secret weapon where, these are the designer drugs that affect parts of the immune system.
yeah,
And we have quite a few of them. It depends on what the patient's co- uh, comorbidities are. What
yeah,
other diseases do we have that we are
yeah.
worried about? And then we can treat them.
Yeah, yeah, yeah. I totally agree with Dr. Nilanjana, which is that her approach is very personalized. So we take each person and we kind of identify what else could be going on with you, and exactly what you said, which is, are you in the child rearing age? Are you in the childbearing age? Right? Is that a primary concern? Are you guys planning another child in another year? Then that would help determine what kind of medications may be an option, or does that person have some other, comorbidities like, maybe high blood pressure, or maybe even, dealing with some other chronic conditions. So we try to make sure that it's not a one size doesn't fit all, and we try to make sure that it's each patient gets an individualized treatment. So thank you, Dr. Bose. So, question about clinical trials, because there's so much going on in the world of rheumatology right now. It's such an exciting time for autoimmune diseases. And so the only way we, at least I'm going to say from my standpoint, is that we get these options that have like exploded. In fact, that is one of the reasons I got into rheumatology, is because you could actually help people. Like before then, they were it was just a hand holding specialty. They were all very nice, but like, you guys are not helping anybody. I'm gone, right? So, so these medications have really kind of revolutionized people's care and outlook and actually lifespan. So, question is, what do you think? What do you think of patients participating in clinical trials? You have any thoughts about that?
Oh, absolutely. I think clinical trials are great. As a patient, you get to contribute to the advancement of science, which is so important. Many clinical trials will, allow patients to have their labs done, doctor visits, all which is covered by the trial cost. Some trials are, of course, placebo controlled, so you may or may not get the active drug. But I do think clinical trials are a great asset to all patients. And for some patients who maybe are not able to afford expensive medicines, clinical trials are a way to get the most up to date potential treatments for no cost to them.
Yeah, I totally agree. We actually have we've been having doing clinical trials last few years, and it's been amazing the results exactly when they're not on placebo. But we've had some patients that we had one patient that was flying from Arizona to come and get her treatments, and she had really bad rheumatoid arthritis. She tried everything. So she would come in, because she lived with her son in Arizona. She would come in, fly down to Seattle from Arizona, probably not good for the environment, just to make sure that she could meet those every 4 week visits. And because she was doing so well on treatment. So it's really been a blessing for patients to really be at the forefront. And again, and we have patients that are participating just because of what it contributes to science and because they're concerned that, hey, if my grandchild is going to inherit this condition, at least inherit the predisposition to rheumatoid arthritis, I want to be part of the solution. So we have people kind of coming and participating in clinical trials just based on those kind of reasons. But I totally agree with you. Without clinical trials, we would probably not have enough options for our patients. The options that we have today, we would not have them. So yeah, we I think we're both on the same page with that.
Mhm.
A question that patients want to know is there any way of preventing? We've talked about treatment of it, talk about how it presents, we talk about, what do you need to look for? We talk about, hey, if you have rheumatoid arthritis, consider clinical trials. But people want to know, how do you even prevent it? Like, my parents or grandparents, I know somebody there had rheumatoid arthritis. I don't want to get it. What do you advise your patients about how to prevent rheumatoid arthritis?
So I think that's a great question, comes up a lot. There are some variables that are fixed and some are modifiable, right? So your family genetics, mostly your environment, these are all fixed variables in your life. You really cannot change them. What is in your hand as a patient would be maybe lifestyle modifications, eating a good diet, exercise, and reducing inflammation and stress. Of course, Dr. Dada and I have discussed gut health is very important and has gained a lot of traction and popularity as we have tried to understand more about how autoimmune diseases and maybe even cancer originates. So, having a gut that is clean and healthy, I think, is a basic foundation for preventing not just rheumatoid arthritis, but all diseases, chronic diseases. So,
Yeah.
if anything, maybe start with that: eat healthy, eat clean.
Yeah, yeah, I totally agree. And there's a lot of information out there about Mediterranean diet.
Mhm.
And as we were talking about too, people ask me, especially after the disease is full
Mhm.
blown. And I really feel that the diet definitely has a role. Because if you're eating pro-inflammatory diet, so especially all the additives,
Mhm.
meat is probably not, I love meat, so you can see how I'm stammering. How I'm stammering. Oh my, yes. So for everybody, including Dr. Dada, a deck of cards, yeah, that is about the size of a serving of meat that you get to have once every 2 weeks. Okay, so that's the truth. Okay, so yeah, so we meat lovers struggle with that. But we at least we know what the right things to do is. But definitely we want to encourage the Mediterranean diet. You want to make sure you're exercising, and pretty much I'm just echoing everything Dr. Bose said. So yeah, so that's I think where if you have a strong family history of rheumatoid arthritis, the gut health is really where we need to look, and that's where the diet modification matters. That's something that's within your two little hands that you can adjust and you can alter the trajectory of your life. Okay. So, Dr. Bose, tell me and tell us, give us an example of a patient with rheumatoid arthritis who had a great experience under your care.
So, this is a very young patient that I first saw in 2018. She was only 23 years old, came to me with her mother. And as a 23-year-old, she had to actually be helped by her mother. Very,
Mm,
very sad case. She
mm.
couldn't walk, her mother had to help her in. And she was a patient of the practice and had been um, not treated aggressively. She had only been tried on steroids, long term steroids, and had suffered complications from that, but had not been on the right track. So, anyway, we got her worked up and then started on treatment. She started on hydroxychloroquine, being a young female, and then quickly her disease was very advanced. She already had joint deformities when she was seeing me.
Wow.
So yes, so she's had disease for a long time. So we started her on biologics. We tried her on Remicade initially, and then she had a partial response, and then we tried a JAK inhibitor called Rinvoq. Um, Rinvoq had just come out when she was tried on it, and she had a fantastic response to it.
Wow. Wow.
So she
So when
still
you say
maintains
partial
the
response, what happened?
with the Remicade. I mean, she had about 50 to 60% reduction in
Okay.
pain.
Okay.
The swelling was hard to evaluate because she has
Yeah.
chronically swollen joints. Her labs
Yeah, it's hard.
improved, her energy
Yeah.
improved, but not
Okay.
100%. I felt that there
Yeah.
was room for improvement.
Yeah. 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 And I think that's, yeah. And so I think that's kind of the good thing about kind of walking hand in hand, with your rheumatologist and just kind of saying, hey, we've gotten this far. Sometimes people are like, you know what? I'm so much better than I used to be. But we're like, hey, this is a goals post. We're really trying to get that inflammation completely suppressed because it's not just about the pain. It's about making sure we get that inflammation under control. Well, that's such a wonderful story for somebody so young to have that. It always kind of touches your heart. And I can see why that's just an important patient to you who you were able to basically change the course of her life. Thank you for that.
No, thank you.
So, Dr. Bose, if you had one superpower, what would it be?
I'd be able to take away everyone's pain,
Oh!
which I wish
Yeah.
every day.
Oh, yeah,
I'm
my
sure you
knee's
do too.
bothering me right now. So
There you
yeah,
go.
that'd be great. Oh, that I love that. Thank you for that. Okay. Well, Dr. Bose, thank you so much for spending time this evening. I know it's late hours for you. But one thing I do want our audience to know is how do they find you? How do they work with you?
We are based in Houston. I do telehealth for the entire state of Texas. They
Wow.
can call us, better text us on our office number 713-588-1674. They can also go to our website lsroom.com and message us there, and
Okay.
come and see me if
Okay,
they
good.
want to.
So you also have social media handles. Yeah,
Yes.
so we have Facebook, Lonestar Rheumatology PLLC, Instagram at LSRHEUM, YouTube at Lonestar Rheumatology 2555, and TikTok at LS Room. So thank you everybody so much for listening. I know for sure that you learned a thing or two about rheumatoid arthritis, but most importantly, if you know anyone in the Texas area, Lone Star Rheumatology is where you want your loved one to go. Like this video, subscribe to the channel, share it, and we'll definitely be back. I'm going to have Dr. Bose back, definitely, because she's such an amazing rheumatologist and she's always a joy to work with. So thank you, everybody, for listening, and we will see you next time for Healthy Joints, Healthy Life. Thank you, everybody.